This is the BBC.
Welcome to Everyday Ethics, your free weekly podcast from the BBC with me, Audrey Carville. On this week's podcast, the state of our health service. Is the NHS model of care as we know it dead? Is it dead operationally? Is it dead philosophically? We asked the question in light of news this week that there are nearly 360,000 cases on a waiting list for a first appointment with a hospital consultant here. More than half of those cases are waiting for more than a year. Accident and emergency departments are at bursting point. People waiting up to 12 hours sometimes in ambulances, hundreds more on trolleys for days at a time. Is the NHS beyond saving? Well, Professor Raphael Bengoa wrote a report on the future of the health service here. He wrote it in 2016. He joins us this morning. Also with us are John Compton, former Chief Executive of the Health and Social Care Board, who I think also wrote a report about our health service here many years ago too. And Christine Lyons is a former Human Rights Commissioner here. And you're all very welcome indeed for joining us. And thank you for being with us. John, I'll come to you first. What are your thoughts when you hear those details in the past week? And indeed, you know, during the pandemic, we got a real glimpse into the brilliance of our health service and especially our frontline staff. But then really, really awful stories as well about the pressures on it and about how it was unable to cope. How would you assess it at this point?
Well, good morning, Audrey. I think the health service here in Northern Ireland is in deep trouble. That's not to say it's broken beyond fixing, but it is in deep trouble. If you see it as having four big engines, acute emergency care, elective care, primary care, that's your general practitioner, and social care, there hasn't been a day last week that part of that hasn't been in the news, and not for the right reason. It's all about problems, difficulties and issues. And fundamentally, of course, it's our perceived inability to reform and reshape our services that's the problem. And that long predates the COVID thing. What has happened with COVID is it has blown that wide open and blown that fragility wide open. And that's what we're dealing with now. I mean, on the other side, on the balancing on the other side, I think you can't say that if you're spending 50% of the Northern Ireland block, which is what we do spend on our health and social care system, and which is over £6 billion a year, like a colossal amount of money, that you can't turn around to a population of 1.8, 1.9 million people and tell them they can't have an NHS service. But we really do need to begin a reform position. We do need to understand that trying to get yesterday's solutions for tomorrow's problems in the health service will only drive us further and further into the chaos that we've seen last week.
Let me come to you, Christine, because this is a very difficult question to have to ask in terms of Christine Collins. I beg your pardon, Christine. In terms of our health service and what they do and what the people who have dedicated their lives to it. But the systems that John has talked about there, they, for many people, are clearly not working. So I'm asking you, as a former Human Rights Commissioner, is our hospital system, is our health system to any extent putting people's lives at risk?
Oh, I mean, both. Thanks very much, Audrey. I'm really pleased to be on the programme. Both as a former Human Rights Commissioner, where we did take a look years ago now at the situation in accident and emergency care. We did a report on that. And now, as Chair of the Patient Client Council and Interim Chair of the Regulation and Quality Improvement Authority, I have to say, there's no point equivocating about it. Yes, people are suffering. People have been suffering for a long time because the NHS, which we all, I think, love and hold very dear, it's part of our inheritance, but it has been allowed to get into a bad state. I think John has very clearly described how bad a state it is in. And what distresses me is that has been known within the system for a very long time. Professor Bengoa wrote his report, which could not have been clearer about what the challenges were and what would happen if we didn't act to move away from that situation. And, here we are in winter 2021 with, as you've put it, accident and emergencies overflowing, people really in despair, sitting on waiting lists, a lot of people having to choose to go privately instead of waiting. Yes, people are suffering. The system is not doing as well as it ought to. But that is not to take away from the fact that every day, every minute, there are people working their socks off in the health and social care system at all levels to give the very best care that they can to the people that they see in the awful circumstances in which we find ourselves.
Yes, and that's what I'm very aware of, and of those people who are doing their absolute best. But I suppose the question is, are some people's lives endangered by the health service, would you say?
I don't think anybody can argue with that. I mean, from my own personal circle of friends, I know people who are really worried because they know they're not able to access the treatment that they should, and therefore their prognosis is not as good as it ought to be. That's just an indisputable fact. And I don't want to get alarmist about it, because there is no point getting alarmist or hysterical about this. When you're facing facts that people's lives are in more danger than they should be, that people are suffering when they really shouldn't be, then I think that needs to translate into a call for constructive, joint action to tackle the difficulties and get the system moving and the system transformed. And it's a complicated, complex, difficult system to change. I mean, if it were easy, it would have been done years ago. It's not easy. It's very difficult. But I think we do need the joint action across the piece, from individual people, from community leaders at all levels, from the health and social care system itself, and in that system at all levels within that system. We all need to come together and say, this is our health service. We have, as a society, invested in it huge amounts of money, huge amounts of effort, huge amounts of people's commitment over the years. And it's now our challenge is to transform it so that it's there for our children and our grandchildren. So I think we can do it if we work together.
Let me bring in Professor Bengoa. You're very welcome to the programme. And of course, we're talking in the context of your report back in 2016 called Systems, Not Structures. You used the phrase burning platform to describe just how unsustainable the current situation was and is of the health service, and how the status quo is not an option. Could you sum up, Professor Bengoa, what you recommended at the time? What was absolutely critical to change in 2016 from then on if we wanted a sustainable working health service?
Good morning. Thank you for inviting me. The main idea in the report was that the health system, which we all built together in most parts of Europe, and in the case of Northern Ireland, of course, as well, was designed for the demography and epidemiology of last century, and which is basically a system which tackles acute disease, acute episodes of disease, etc. And Northern Ireland population, like in other countries, had been moving on in the last 30, 35 years, has been moving on to a completely different type of epidemiological structure, basically people with many, many chronic diseases, about 1/3 of your population. And the population here, for example, in Spain has one chronic disease and many have several. Now, our health system has not moved on to adapt to that. So to be planning on structures was okay last century, but is no longer okay this century, because these people with many chronic diseases, what they need is continuity of care. And they are not getting it just about anywhere. So most countries are trying to make this move towards a more integrated system, something which was also pre-designed before the report we did. And I think Northern Ireland was looking in the right direction. The absolute new thing in Northern Ireland when we were working there as a group was that the political parties had agreed on the burning platform that I've just described, and had agreed on the interventions which were needed, which was basically start thinking the whole thing like a system with primary care better connected with social care and hospitals, etc. And therefore, that system can obviously provide a more integrated system. Now, in other countries, we did not have that, let's say, political confluence, and that was very powerful. So I think when we just heard Collins talk about joint, that's precisely a joint at the macro level, at the political level, because that's where the main intervention is needed right now in order to push the reforms through.
But I wonder, Professor Brengoa, in it's 5 years since you chaired that committee and wrote your report. We've had the pandemic. We're still living through the pandemic, our health service under fierce pressure. Is it too late to change it under the current model of NHS care that we use? Is it time to say that current model is dead and we have to start again?
Well, the report was about starting again towards a different model, and you need to go step by step towards that model, because the leap towards an integrated system is hard to achieve. Now, some steps have been taken by the administration. I know they're in Northern Ireland, and they've been pushing through, but at the same time, obviously, the pressure from this demography and this chronicity is greater than the changes that have been able to be pulled through. Now, what is important, and because it's also happening in other countries, and with that I do not want to dilute the crisis you may be in, is that as we go forward, it is not too late, it is necessary to reinforce the public system, because private care is beginning to rise. Private insurances in many countries are rising, and therefore there's a sort of laissez-faire in many countries, which is permitting, without sort of in a slow-burning way, allowing people to vote with their feet and to go to seek private care. So you're going towards, let's say, a system which nobody wants, and none of the political parties that I met 4 or 5 years ago wants, is a system which introduces even more inequalities into the system. So we need to reinforce now the public system. It does mean a bit more money, because these changes cost money, but it also means the reconfiguration of the system in the way we just described.
John, do you agree with much or all of that?
I would agree entirely with what was said. I think it's very disappointing to see that we've driven many people in Northern Ireland into private care, because ultimately, if you're in pain or you can't see because you need cataract surgery or something like that, and you can't afford it, of course you're going to go and solve that problem. And I think the difficulty is we don't really appreciate the long-term implications of that change, because a really good health service, and at the core of the NHS, is this view about health inequality and about giving everybody the same opportunity. And if we're not careful, we'll drift into something else which has been less acceptable to us as a society. In my view, this is a moment for real leadership and clarity about accountability. We need leadership in terms of political leadership to reaffirm that change is going to happen and support for the change. We need leadership, both at management and professional levels, to drive that change. Change doesn't happen just because you want it to happen. It happens because you put energy into making it happen. And for me, at the centre of all of this is the need to make sure that we have a really robust approach to the leadership of our NHS in Northern Ireland, and a robust approach to where the population know who's accountable for what. I think in recent times it's become more confusing for people. Who's in charge? The old question, who's in charge, gets asked, and I think people are confused about that. So I do think it's very, very important that we spend some time making sure that the leadership is clear, that the direction is clear. And I know things are very difficult with the COVID situation, but we cannot allow it to become a binary choice, which is we do COVID and we don't do anything else. Because actually the implications for people are colossal. And we hear it all the time, don't we, about people who have cancer being delayed in their treatment and therefore not as good an outcome. People who have orthopaedic problems being delayed and having to live with pain. People, as Professor Bengoa says, with chronic disease, having to live a very difficult life. You know, we can't allow ourselves to have just a binary choice, one or the other.
Christine, there will be many who take the view, and particularly in the opposition at Westminster, would accuse the Conservative-led government of deliberately running down the health service in order to increase the privatisation of it. They deny that, of course. But in terms of the growth of private medicine, is it killing the NHS model of care? Are we at a point where we have to admit that the NHS, as envisaged, as operated for the last number of decades, is dead?
No, and, you know, I think I'll be bold and say that I think there are an army of people in Northern Ireland who would be quite happy to fight against that. I don't think it is dead. I don't think it can be dead. In fact, I think it's very interesting. The concept of the NHS originally was free at the point of care, point of delivery. And there's different ways you can achieve that. And I have a sneaking suspicion that if I were a private sector provider of healthcare, I would be quite delighted to get a nice contract from HSC Northern Ireland to deliver, as it might be, cataract operations or hip operations, because I would know that I was sure of getting paid, and it would be a nice, steady income stream. And if I'm a patient, I don't think I particularly mind whether I have my operation in Musgrave Park or in one of the private provided hospitals. Provided my hip is done, I'm happy. So I think there's more than one way of slicing this. But if I can just say that I think there's no point everybody looking for leadership somewhere else. People have to step up and provide leadership themselves. They have to get engaged. They have to get involved. What I want to do is put in a plug for the Patient and Client Council, because we've just established citizen hubs, one in each trust area across Northern Ireland, where people can get round the table. Well, it's a virtual table now because it's on Zoom, where people can join in and talk about the issues, raise the concerns they have in their local area. Beyond that, we've also established what we're calling engagement platforms on specific areas. So, for instance, we've got one on learning disability. Those are more focused on the issues around those topics, big topics. But people with a particular interest in those can, same way, get round those Zoom tables, say their piece, learn what is going on, and most importantly of all, influence what's going on, because the output from those forums is fed in to the department, to the trusts, and influences quite powerfully what actually happens. And then at the very basic level, there's our membership scheme. People can sign up to our PCC membership scheme and get a trickle of of information coming through regularly about what is going on in the health system. So, because I think it's essential that we have health literacy, that people understand far better than they do at the moment what our health system is like. They understand, when they've got that information, how they can powerfully engage with it, influence it, make their views known, make the change happen. Because Professor Bengoa is quite right. We need to transform this system. It's a big, complicated system. We have got to get it moving. And the only way we're going to get it moving is if everybody in Northern Ireland joins in getting it moving. So we're now getting the mechanisms in place that we can bring people power, if you like, into the equation. And I think that's maybe one of the things that has been missing. We haven't had effective mechanisms for bringing people power in to making the change. We're now getting those mechanisms, and I would ask people, please use them, because this is our chance to make that system better for the future. We mustn't miss it.
We are discussing the state of our health service this Sunday morning, and you've been listening to Christine Collins, former Human Rights Commissioner. We're also joined this morning by John Compton, former Chief Executive of the Health and Social Care Board here, and Professor Raphael Bengoa, who wrote a report on the future of the health service here. He wrote it back in 2016. He is joining us as well. And Professor Bengoa, I'm wondering where you stand on the introduction of private medicine within the NHS. It clearly undermines the philosophy of the foundation of the NHS, free at the point of delivery, free at the point of need. And it is a real ethical dilemma. Do you allow it in order to reduce waiting lists, or does it create that two-tier society where only those who can afford to get treated with priority?
Well, you tend to go towards what was before Obamacare in the U.S. If you rely on both private insurance and private provision. Although the key issue is to have to be looking at what the data are saying and what the citizens are saying in relation to whether they are moving in big magnitude towards private insurance systems. I think the important thing is to stop that, and I think it is not a question of regulating so that citizens cannot do that, of course, but it is a question of reinforcing the public system. Let's say you don't reinforce the public system by attacking the private system. You reinforce it by reconfiguring the public system in the direction we all three have been talking about. I think COVID can be, as Dr. Compton was saying, a distraction in a way, because if COVID has this tendency of maybe not becoming so endemic next year, and this means that we're going to be dragging on with COVID for quite a while, maybe not with the terrifying numbers of deaths we've had up to now, but we have to begin to assume that COVID is here to stay, and that means in planning terms and in health service terms, it cannot continue to be something which stops the broader issues of reconfiguring things in the way we're saying. So COVID has to be seen now as something, of course, to be stabilized, and I suppose that, of course, that's what the administration also wants. But it is an opportunity. It has to be seen as the opportunity to break into the new models of care that we're discussing. That would mean, apart from the citizen participation that has just been mentioned by Christine Collins, it means, I think, the political parties, they may be doing this, because I'm not sure whether they are, but have to get together again and say, okay, what is it that we can do now at the macro level to stop this privatization tendency, because it's not looking good. And at the same time, as we stop that, at the same time as we do that, we make sure that we start reconfiguring politically the health system, because I think it needs this the policy level leadership right now, because it cannot be something which can be handled